make it no fault of their own.
Who is a good?
You're live, Dr. Spears, you're live.
Who just knows how to record?
That's my question.
Yeah, I have no idea. Yeah.
Tyler, you learn no matter what you do, there's always going to be somebody who will take issue or whatever with it, so.
They're called haters.
So Paul, you want to be the official person?
I got you recorded right now.
Yeah.
Oh, well, I better get going then.
Oh, you're actually
Yeah.
recording. That's pretty genius.
Do I need to use the
We
mic?
got,
do-
we got
we
the
can do a live
back
stream
of
on
one's head.
Facebook.
You can be in
Do I
there
need
the
to use
whole
the
time.
mic for you guys, or do I not need to use the mic?
I think you should pick it up.
Put it up by.
Need to see if it'll work.
You want to do that?
You know what I'm saying? Because then you won't have to use the mic.
So I'll use the mic.
Okay, never mind. Now you don't have to do that.
Okay. The problem always with something being recorded is it's being recorded. So I have to be careful what I say or whatever else. So let's get going. I've heard from multiple of you, and I'm pretty familiar with, I think, where most people are having some concerns and issues right now. So let me speak. So obviously I got osteology up first. So from the osteology lecture, I would just say, this is similar to last semester for the lecturer who gave this stuff. If you know the extra stuff written on the osteology slides, you'll know what you need to know. Okay? So as you go through, make sure. The problem is that's not there for the skull stuff. And I know that's where some people are having some difficulty trying to know what's going to be tested on the written exam versus the practical exam. So hang tight, let me try and go through that stuff. So definitely know the difference between axial skeleton, appendicular skeleton. It's almost pretty much, if you can draw a line straight up the midline and touch it, it's part of the axial skeleton. But that's got to include the ribs, so a thicker line, okay? If it doesn't touch that line up the middle, so things like the arms, the legs, and then the two girdles for the upper limb and lower limb, those are appendicular skeleton. Pretty straightforward. All right, so off of the vertebral column, he made the point that there are what he considers true vertebrae. Note there are 24 true vertebrae consisting of 7 cervical, 12 thoracic, 5 lumbar. The other 5 sacral, 4 coccygeal are fused together, and he's not listing those as part of the, if you will, vertebral column, or at least the true vertebrae. So 24 such. As I mentioned, go through his slides, and if there's any little extra stuff or whatever, know about that. So mentions about rotation and movement. There's a slide coming up in just a minute that will talk a little bit more about it. But the articular processes themselves tend to limit this rotational and other movements within certain vertebrae. They all will form or cause stabilization of the different vertebrae. But I got a slide coming up. We'll talk more about that in just a minute. In the lab, I don't think you would be wrong either way if you said facet versus demifacet on the body of the vertebrae. Understand that one rib articulates with 2 vertebral bodies. So each of these would be a facet or demifacet for the head of one particular rib, and then the tubercle of the rib will make the facet that you find on the transverse process. The transverse processes, Sunday, thoracic vertebrae have a high degree of rotational movement. Always want to know about that. For the cervical vertebrae, make sure you know this slide and the things that are on it. That classically, they'll all have the transverse foramen. They typically have a bifid, or what we call a split spinous process to it. Let's see. They are laterally tilted so that the process prevent rotation. At least most of the cervical vertebrae, hopefully you know that C1, C2 do allow for rotation, but the rest of them have these little saddle joints that are present that bend but do not rotate. So you know that the DENS is part of C2, pivot point for rotation of the skull. So when you basically say no, that's rotation of the head at that point. So C1, C2 allow for rotation. The thoracic vertebrae will rotate, the others pretty much do not. Which is what this slide says. These are straight out of his lecture. It's got something written on there beyond just those pictures. Look it over. All right, he made a big point about the intervertebral structures that are present. So between the different vertebrae, we have these discs that are present that consist of two components, the annulus fibrosus, the strong outermost ring, and then the inner portion is called the nucleus pulposus, kind of a more gelatinous-like material that's present inside of there that basically allows for compression and allows kind of a shock absorber function, if you will. So the thing to remember is whenever you herniate a disc, what you're talking about doing is you're perforating the annulus fibrosus, and some of the nucleus pulposus will extend out, and that's how you herniate a disc. And typically, I thought I put the slide in here. If you herniate a disc, it's typically going to perforate and go posterior, like posterolateral. That's why you tend to get compression upon a spinal nerve as you do, because these things will break, goes posteriorly. That's where the spinal nerves and to some extent the dorsal root ganglia are situated. So that's why you tend to have compression on a nerve and you get problems with that. So that was kind of the bulk of stuff. No, it wasn't either, sorry. So we went through about a typical rib. It's easy enough of knowing. If you know where the head is, so this is the head of the rib. Here's the tubercle. The area between the head and the tubercle would be the neck of the rib, angle where it bends, and then you all know where the costal groove is, situated such that you have a neurovascular bundle in between there. The head with two vertebral bodies, the tubercle with one articular process. You can always tell a thoracic vertebrae because there will be facets on both the body and the articular processes for a rib. Remember, you can tell cervical vertebrae because it's got transverse foramen. They're the only ones that have the transverse foramen. The only ones that have costal facets will be the thoracic vertebrae. And if you're a vertebra that has neither of those two, you must be a lumbar vertebrae. Simple enough. Yes, ma'am?
Can you repeat the herniated disc thing, like what it affects? Which pulposus? Is it
The
both?
nucleus pulposus tends to perforate through the annulus fibrosus in a posterior direction, and what's passing by that area would be your spinal nerves coming off the spinal cord. So if you compress spinal nerve, if it herniates badly enough, you can compress the DRG, but that's a really severe herniation if it does that. But spinal nerve is the biggest thing it's going to do. Okay. So one point he made, big point he made about the sacrum was this sacral hiatus. He made a point about it being the place for anesthetic injection. I think he had a different slide in there where you can put your thumb or finger or something there, and it was a guidance point for doing the injection. But that's where basically you do an injection, the anesthetic will go up and can anesthetize nerves that you're trying to anesthetize. So make sure you know about that. 5 vertebrae, use of birth. There you go, the sacrum. So I knew I had a slide, I didn't realize it was not till later. So this talks about the herniation. So you see how, remember this is posterior, that's anterior. The body's always anterior, spinous process posterior. So when it tends to rupture in a posterior direction. It doesn't, it shows pressing on the spinal cord, which it can, but typically it's more, it'll come out in a posterolateral direction. And typically it's going to press more on like spinal nerves. So it talks about sensation. So if you're typically herniating in the lumbar region, typically getting something like nerves that will contribute to sciatic nerve, numbness or whatever, tingling. But that's what I was trying to get to with that. I had the slide up there. To remove that pressure, to alleviate what's going on, the best route is to do what's called a laminectomy. So literally they'll come through and cut out the lamina to open up the space such that that bulge can go this direction instead of pressing upon spinal nerves or some of the other structures, it'll actually allow for that bulging to extend posteriorly. And you've got enough musculature and other stuff present, there's a bunch of ligaments that are there, such that it's not gonna bulge out and press on some other things, but it at least alleviates pressure off of the spinal nerves by doing a laminectomy. Let's see, for this one, it was just getting people to understand that for sternal angle, it's where the manubrium articulates with the sternal body. So this point right here where the second rib articulates is the sternal angle anteriorly. And I think you were given T4, T5 is the posterior boundary for the sternal angle. And then, as I'll mention in a couple of minutes, it's knowing kind of what structures or things that might lie relative to the sternal angle that Dr. Nguyen talked about. I already talked about that. Okay. Any other questions about osteology? Just say no. No? Perfect. Great. Know that stuff. Know what's written on the slides. You're golden. Okay. Dr. Nguyen's material. She will be straightforward and write questions that you could have answered probably when you were in junior high or something of that nature. So there shouldn't be too many problems relative to what she'll write. So she made a point about certain things relative to the pericardium. You should know about its 3 layers, that there's, you know, the outer fibrous pericardium, and then inside is the serous pericardium. It's made of an outer parietal pericardium, and then on the heart itself is the visceral pericardium. Basically, the visceral pericardium is the epicardium of the heart. Situated between the 2 layers of the serous pericardium is a space for the pericardial sac. Remember, this is a serous secreting structure, so it lubricates the inside of that pericardial sac such that if the heart beats, it beats in a friction-free environment. If by some chance you lose the ability to secrete fluid from that pericardial membrane, oftentimes what happens is you'll develop something like pericarditis. That pericarditis, the sensory information from that is going to be transmitted by phrenic nerves. You tend to think about phrenic relative to the diaphragm, being both sensory and motor to the diaphragm. You need to remember that the phrenic nerves are also sensory to the pericardium. So if you got some sort of irritation or whatever relative to the pericardium, phrenic nerves. Great vessels coming off the heart. We have vessels going, so always remember, venous flow, one direction. Mike, was that a question or no? Just grooming?
I'll wait and then I'll ask my question.
Okay, you can keep grooming then.
Okay.
Remember, venous structure taking blood flow back to the heart, arterial structure taking blood away from the heart. Typically, I would have said there's an exception to that. There is an exception to it. What wouldn't fit that bill? Pulmonary veins. So the only ones that are really going to be a vein that takes blood back to the heart. You could say coronary sinus is a venous structure taking blood back to the heart. Middle cardiac vein, great cardiac vein. But most people writing questions aren't as dastardly as I am about that sort of stuff, so you won't have to worry about it. So superior vena cava being formed by the right and left brachiocephalic veins. And you need to know that the brachiocephalics are formed by the union of the internal jugular and subclavian veins. Yes, sir.
Okay, I have 2 questions. So where does the external jugular run to, or where does it connect to?
The question is about the external jugular vein, where it's draining into. That's a pathway that you're not going to worry about.
Okay, and then the mediastinum, I know on one side it was saying that all of the top portion of the heart, all where the blood's going out and in, it was saying that it was in the superior mediastinum, but then it was saying in another slide that the aorta is in the middle. Do we need to know that difference between?
Questions about which structures are located within the mediastinum. So what I would say is some structures can be located in different or multiple parts of the mediastinum. So you think about where the
Yeah.
you think about where the aorta originates from. Okay, it starts off in the middle mediastinum because it's coming from the heart.
The baby head smell. Yeah.
That's the best smell. So it can be in both parts, 2 different parts of the mediastinum. Okay, and actually, you could have said it was in the middle mediastinum because where it came off from. It travels up in the superior mediastinum as the arch of the aorta, and actually goes down in the inferior mediastinum as descending aorta. That's a level you're not going to have to know.
Okay, okay.
Okay? Careful what you ask.
Yeah.
You get a description. So everybody should know what forms these vessels. I don't think, I kept pointing out in the lab that somebody mentioned to me that wasn't on there, but it never hurts to know that the azygous vein comes up and drains into the superior vena cava. It doesn't form superior vena cava, it drains into it after it's already formed.
Yeah.
Okay, so you should know that there are three things that drain into the right atrium, three venous structures, if you will. Superior vena cava, inferior vena cava, and then the coronary sinus. And if anybody ever read that there was a fourth thing, yes, but we're not making you learn it. So those three things drain into the right atrium. So if you know that basically right about the level of where the sternal angle is, about where all the great vessels are coming off and going in relative to the heart. So then always remember, what are the first vessels that come off of the aorta? And don't tell me brachiocephalic trunk, because it's not. It's always the coronary arteries. Coronary arteries branch off first, right and left coronary artery. The first thing to branch off of the arch of the aorta is the brachiocephalic trunk. But the first things to branch off of the aorta are the coronary arteries. The heart gives blood supply to itself. I'm scaring her, I know. The heart gives blood supply to itself before it gives blood to anything else. Okay? It's important. The heart's a muscle, just like the biceps is, or something else. Biceps, that's like the biceps. So it's a muscle. It needs blood supply, needs venous return after that. That's what those great and middle cardiac veins are for, is to drain the heart muscle itself. So right and left coronary artery, everybody knows the branches. I'm not going to go into that. Same thing with the arch of the aorta. Everybody should know brachiocephalic trunk, dividing into right common carotid, and then right subclavian, left common carotid, left subclavian. Easy peasy. Yes?
So this is kind of related to lab, but where does the posterior interventricular artery actually begin?
The question is, where does the posterior interventricular artery begins? As you can imagine, for almost every heart, it's different. What your main thing is, what is the posterior interventricular branch of? Right coronary. And if we were going to tag it, where are we going to tag it? In the posterior interventricular groove sulcus. Okay? It's not trying to get into splitting hairs about, is it back up here? We would tag it in the groove, so you know definitively we're getting that, not right coronary. You're hoping we tag that, 'cause that should be straightforward, no problem. Okay?
Dr.
So,
Spears,
yes.
if you were to tag that, would you tag it like, what is this vessel or what is
Oh
this
my
groove?
gosh. You're in dental school, you're
How
in
do we know if
professional
it's a groove
school.
or a vessel?
Basically, you should be able to stick a pin in that sucker and you know what it is. There will be a card at every station you go to, and oftentimes he has some sort of little thing that's supposed to help. It might say like vessel, question mark, okay? Sometimes that hurts more than it helps, because sometimes he'll use a word and you're like, what? So, anyway, yes ma'am?
What's the best way to differentiate between like the posterior interventricular artery and like the middle cardiac groove?
The best way, everybody should know what I'm gonna say. Where's it coming from, where's it going to, where's it located, what's its landmarks? So you got two structures on the back of the heart. You should be able to trace one going right up into the coronary sinus, so know definitively it's the middle cardiac vein. One should follow up and go right into the right coronary artery. Where is it coming from? Where is it going to? Always. And most of you heard me say in the lab, whatever, a suggestion I always have is to have landmarks, boundaries, whatever, such that when you look at something, you know what it is. Check it off in your brain mentally. I say it's like checking math homework. Okay? I think this is the posterior interventricular artery. How would I verify it? Where does it go to? Easy peasy. Okay? Same old, talked about that. So make sure relative This is pulmonary trunk. It divides into a right and left pulmonary arteries, head to the heart. I'll talk about more in a minute. Everybody should know that's ligamentum arteriosum. I'll talk more about it specifically in just a moment. Apex, face of the heart. I'll talk about that in a moment because there's a slide talking about it right here. So what was important? So if you understand, this is the apex of the heart, and then kind of right up here is going to be like the base of the heart. It helps you understand that when the ventricles in particular of the heart contracts from apex to base. Because if you look, so like right here, here would be where the pulmonary valve is, over here is going to be where the aortic valve is. You want to squeeze the ventricles such that it's forcing blood to go this direction. If you were contracting base to apex, you'd be pushing all the blood this direction. How's it going to leave the heart if you're pushing it towards the apex? You want blood to go towards the valve. So by contracting here first, it'll do that. We'll talk in a minute about how conducting system, that's why it comes down and then goes like this. So get the apex to contract and then up towards the base. Make sure you know, as you point this out, that this, listening for the apex of the heart, it's always done at the 5th intercostal space on the left side. So that's where doctors listen to. There are two sulci going around the heart. There's an interventricular sulcus that goes from, both sides of the ventricles, and then there's an atrioventricular, sometimes you see called a coronary sulcus, going between the atria and the ventricles. So you should know what's located within the interventricular sulci would be the anterior and posterior interventricular arteries, great cardiac vein, middle cardiac vein. The atrioventricular sulcus or coronary sulcus going around, what would you find in there? Right and left coronary arteries, circumflex coronary artery, coronary sinus. Somebody said, well, what about the posterior? And yeah, don't worry about that. It's not what we're thinking relative to being in this group. It's really this group. So I'll obviously learn what's in the different atria and ventricles. And you know how faculty tend to write questions is, what's the one thing in this one, or what's not in this one, that sort of thing. Everybody always tends to ask exceptions, all right? So in the right atrium, make sure you understand that this structure right here, crista terminalis, is a right atrial structure only, not in the left atrium, not anywhere else. It's an invertilogical remnant that separates the pectinate area from what becomes more of a smoothened surface of the heart. So crista terminalis. Pectinates are in both right and left atrium. I think it tells you pectinate tends to be more in the auricle on the left side, but they're in both sides. Fossa ovalis tends to be more of a right side structure than the left, but you can see it in the left. What is in the right atrium that would be anywhere else would be the opening for the coronary sinus, and then the opening for the right interventricular tricuspid valve. I don't even know if I put each one. Right ventricle will be unique and it's going to have the moderator band. Left ventricle will not have a moderator band. It's taking the signal across, so as the bundle of his comes down and branches out in the right and left bundle branches, it's going to take KG fibers across, stimulate these papillary muscles, then go to the other side of the ventricle. So this is unique for right ventricle. Both ventricles will have papillary muscles. Both ventricles will have trabecular carinae. Understand that the right ventricle will have 3 papillary muscles because it's a tricuspid valve. The left ventricle will only have 2 cusps, so hence only 2 papillary muscles. Both sides will have chorda tendineae, cusp. You know that the wall of the right ventricle will be much thinner than the wall for the left ventricle. And then the right will distribute its fluid through the pulmonary or pulmonic valve. Left side will go out through the aortic valve. Okay. There's not much in the left ventricle or left. The only thing that's different left atrium is that you've got the openings for the pulmonary veins, a little bit of pectinate up here in the auricle. Left ventricle, trabecular carinae, no moderator band, 2 papillary muscles, chorda tendineae, cusp, that sort of thing. So understand that, you know, inside of here, there's trabeculae carnae that form the wall, and then there's papillary muscles that are gonna be involved with, controlling what's happening with this valve. Papillary muscles contract, pull tension on the chorda tendineae to keep the valves closed. They don't open the valve. They keep the valve closed during ventricular contraction. Because what you want is, when this contracts, I want blood from here going out the pulmonary valve, excuse me, the aortic valve. I don't want it blowing back up through the bicuspid valve in the left atrium. So it's like a bunch of little men down here pulling on those cords to keep the valve from evulsing back up into the left atrium. Layla, you had a question?
That big wall around the ventricle, that's not the trabecular carnae, right?
The trabecular carnae helps make up that wall
Okay, so if,
internally through here, but you don't have trabecular carnae on the outside.
okay, but on the inside,
Let's just say it's part of the myocardium of the ventricle. Okay? Yes, sir.
I don't understand how papillary muscles keep it closed when, like, if they contract, it'll open the valve.
The question is, how is it that when these contract, they're keeping it closed, why aren't they opening the valve? Which you have to, trying to make this more complicated, and I don't want to spend a lot of time, you don't have to know it. You probably didn't have to know that part of it. But the thing is, you have to think about what's going on in the ventricle. You're building up a ton of pressure. So those muscles are acting against the pressure. So all the pressure that's inside the ventricle when it contracts is trying to blow that valve open, right? What opens up that aortic valve is literally pressure. Okay, the aortic valve doesn't have chorda tendineae and these papillary muscles attached to it. It's different. Cuspid valve, okay? Sorry, leaflet valve. So what happens is, it's like pockets, okay? They open up, they fill up with blood, and when enough pressure contracts in the heart, pops it open. What closes it? When all basically the blood's been taken off by the aorta, pressure diminishes to a point where the valves pop out. It opens, blood fills them, and it shuts itself off. So these are basically trying to hold pressure while there's pressure so that the valve doesn't go back up. Yes?
So they're doing the same thing in that ventricle as the moderator band does.
No, let's don't even go there. Yes?
Is trabecular carnae kind of analogous to pectinate muscles, but just like it?
No. Trabecular carnae has nothing to do with pectinate muscles. Pectinate muscles in the right atrium only, so I'll start talking about a whole bunch of stuff that y'all don't need to know, you don't care about. Maybe I'll come back and tell you when you do the cardiovascular system, but trust me, just no. Okay? No, don't go there. It all has to do with contractility of the heart and how the heart contracts. And for Wednesday, don't worry, I should have even brought it up. But you know, when students want to learn, teachers want to teach. And you know me, I just want to teach no matter what. Okay, heart sounds. So make sure you understand the whole, talk about lub dub. So make sure you understand about the first sound, lub, is basically due to basically valve closure. Okay, so basically tricuspid, bicuspid valves closing gives you that first sound. And then the second sound is going to be the exact opposite during diastole. It's going to be some other valves doing their bit, closing off. So just the two things she's got in these slides, know what causes lub, what causes dub, and you'll love the question. Yeah, I know. Anatomy jokes are pretty bad. I would go through this slide and make sure you know about which sounds you can hear at which spaces. So just go through, it's the ultimate in rote memorization since you'll probably almost never be doing this. So for the conducting system of the heart, make sure you have an understanding of real basics of the signal, that you're going to start from the SA node, the pacemaker of the heart, and heartbeat is set by the SA node. If you were to take the heart out, set it on a table, it'd still keep beating because the SA node causes the conduction. It's what causes that heartbeat. Autonomics modify the heartbeat, but that thing is what causes heartbeat. Yes, sir?
Can you explain that pause for the 0.1 second for the atrial muscles?
So you're saying right here what happens, okay? From the AV node down. So anyway, you're not gonna have to know it. Basically, you have here what's referred to as the cardiac skeleton, connective tissue structure that's separating out between the atria and the ventricles. So what happens is, you need a little bit of a pause such that the atria contract and then the ventricles contract. You don't want both of them going at the same time. So you want lub, dub. And so the way you get that is you have a little bit of a pause here at this skeleton. So pause at the AV node. Well, this it sends a signal down SA node, sends it to the AV node, and there'll be a pause there, and then the signal goes down, to the bundle branches, out to the Purkinje fibers, and gets the signal all out to the ventricles. But you need a little bit of a pause, a little bit of a delay, such that you don't have atria and ventricles contracting at the same time. That's what happens oftentimes when things go wrong, is you're not getting that coordination between atria and ventricles, and heart's not working right. Okay?
Does that kind of have to do with what you're talking about, it starting from the apex up?
Well, it's not even so much that, it's just that if it all went, you gotta think about this, signals go really fast. I mean, faster than I can snap, all right? So if you've got blood going up before, while these are still trying to empty, that would be a bad thing. So you want the atria to empty, then the ventricles are gonna empty. So the way you do it in unison is to have just a slight pause here so that you can make that happen. And again, she's not gonna ask you that. She wants you to know SA node to AV node, this is gonna go down to the bundle of His, right and left bundle branches, going each way, then it goes out to the Purkinje fibers, and it innervates or stimulates individual myocardial cells. Two structures relative to fetal circulation. You guys know about this, you're familiar with it. You have in the fetus, what's referred to as foramen ovale, and then up here you have a little structure going from pulmonary trunk to the aorta. It's called ductus arteriosus. So if a question asks about structures in the fetus, it's ductus arteriosus, foramen ovale. In the adult, it's going to be what? Fossa ovalis and ligamentum arteriosum. It's all about trying to shunt blood away from the pulmonary circulation and getting it to the systemic circulation. So foramen ovalis is taking some of the blood, not all, it takes some of the blood, and instead of it having it going up into the pulmonary circulation, it takes it right across to the left atrium, left ventricle, and it goes out to the fetus. Because remember, where's the fetus getting its oxygen supply from? From mom. It's not breathing air in, it's getting it through the placenta and coming in through the umbilical vein, so that's how it gets its oxygenated blood. And then the other shunt is some blood does go up in the pulmonary circulation, some of it will actually go straight over to the aorta to go out. Some still goes up through the pulmonary artery, but it's not going up to the lungs to get oxygenated. It kind of keeps the whole system working like it's supposed to, such that when you're born, it'll switch over and you're set to start breathing on your own once you're born. But it's just basically trying to bypass pulmonary circulation to some extent and dump blood into the systemic circulation. Okay, so that's what that is. Oh, I know I've got this on here. Okay, so make sure that in the mediastinal area, whatever, relative to the diaphragm, you know the three openings and at what levels they occur at. So you need to know inferior vena cava is at T8, esophagus T10, aorta T12. So just whatever mnemonic you want to know, go for it. Just know those three openings where they occur. I think I put this on, I'd already mentioned external angle relative to anteriorly manubrium body, posteriorly T4, T5 level, and should be golden. Okay, any questions? Yes, sir.
On one of the slides, it was talking about an anastomatic
Anastomose. So
anastomatic loop.
anastomotic loop? Are you talking about on the heart?
Yeah. Yes.
So, one thing I'm gonna have to train you for, Michael. It's always great you want to learn. If I don't talk about it, don't worry about it.
Okay.
All right. So what we're talking about is in the atrioventricular sulcus, in the interventricular sulcus, the structures that are present there tend to form two anastomotic loops with each other. In the atrioventricular sulcus, right coronary artery anastomosis with the circumflex. In the interventricular sulcus, the two interventricular arteries anastomosis with each other. Because that way, if you lose some blood supply from one of them, you still have the other one providing it.
Oh, okay.
Yes, sir.
So just, you didn't talk about thoracic valve or
I didn't, but I'm not gonna say, I'm not gonna say, oh, everything I said is, or I'm gonna talk about as a question on the test. I mean, I'm giving you, I think, some stuff that will help. Only thing you would need to know about thoracic duct is it empties into the union where you form the brachiocephalic vein on each side. Well, thoracic duct only goes on one side. There's another thoracic structure on the other side. So where the internal jugular, subclavian come together to form brachiocephalic is where the thoracic duct goes in. What was the other thing you mentioned? Descending thoracic aorta. Nothing I need to say. Okay. Anything else about thorax, heart? Outstanding. Let's do that. Okay. So, as you know, we need to know a few things about fascia. No, we're not going to tag fascia on the practical. Okay? Should be easy enough, but we're not going to do it. What I want you to know, I think I had a pretty good conversation with a person who might have written questions for the neck region. So this area right here would be the posterior cervical triangle. I had a slide in one of the lectures about it. So you should know, and I've mentioned this over and over ad nauseum, so the roof of the posterior triangle is formed by the outer investing layer of the deep cervical fascia. The floor is by the prevertebral fascia. Okay? On the anterior one, I mentioned it was still outer investing, and it was more with like pretracheal, carotid sheath. So just kind of know that bit. You know that outer investing has sternocleidomastoid trapezius in it. Prevertebral has the muscles that we saw deep to the floor. So 3 scalenes, levator scapulae, splenius capitis, those are all the prevertebral muscles. Okay? So there's a space between those two fascia, which is holding the contents of the posterior cervical triangle.
So even though those muscles are deep to that fascia, we still consider them part of the triangle?
The question is, since those muscles are considered deep to the triangle, would you still consider them part of the triangle? That's splitting a hair I wouldn't do. Okay? Can you see them through the posterior triangle? Yes. Sure you can.
Over the fascia?
Yeah.
Oh, okay.
Yes.
Is the platysma superficial to the fascia?
The platysma, it depends which fascia you're asking me about. The platysma is wrapped up in the skin, so it's basically just deep to the superficial fascia, but it sits, if you will, superficial to the outer investing layer. It's in the skin. Yes? I haven't even said them yet, I don't think. I'm about to, though. I didn't think, did I say the boundaries for the triangle?
You said the roof.
Oh, you're talking about for the fascias? Yeah. So basically, the outer investing layer forms the roof of the posterior cervical triangle. The prevertebral fascia forms the floor of the posterior triangle. And then boundaries. Oh, well, you know I'm going to talk about boundaries. You got to know boundaries. So, okay, you know that we have certain muscles that we use to form the different triangles. First off, everybody should know, and I've got different slides coming up, but, you know, trapezius, sternocleidomastoid, omohyoid, and then the digastric. Those are the muscles that really are used to form the different boundaries of the different triangles. You know that here's trapezius, sternocleidomastoid, clavicle form the posterior triangle. We subdivide the posterior triangle into 2 triangles with the inferior belly of the omohyoid, forming the supraclavicular triangle and the big occipital triangle. Most of the contents of the posterior triangle are in that occipital triangle. And then I'll talk in a minute about taking the anterior cervical triangle and how we use stuff to split it up into 4 triangles. And the big one is, you know, carotid. We'll talk about muscular contents. So anyway, 2 posterior subtriangles, 4 posterior subtriangles. Okay. Sternum, I've already talked about that. Posterior triangle. Yep, anterior triangle. We talked about that. Let's go on. Okay, so the anterior triangle, you would basically use sternocleidomastoid, posterior digastric, omohyoid, to separate out carotid triangle. We have a submandibular triangle that's going to be the two digastrics, anterior, posterior digastric with the mandible. Okay, and then I'll show you a different slide in just a moment for submental and muscular. Probably coming up next. So submental, you know, is between the two anterior bellies of the digastric hyoid bone, and then muscular triangle being midline of the neck, sternocleidomastoid, sternocleidomastoid. What did I just say? I know. As soon as I said it, like, what did you just say? Midline of the neck, omohyoid, sternocleidomastoid. Sometimes the brain knows what it wants to say and the mouth doesn't cooperate. Okay. Submental triangle is not one we're going to worry so much about. You know, there's not much in there other than some submental lymph nodes, submental artery crosses through there, whatever. Submandibular gland is going to have things like the submandibular gland, facial artery inside of there, so not a whole lot of contents. Muscular triangle is pretty much going to have the infrahyoid muscles and viscera of the neck, such as thyroid gland. They'll have the thyroid cartilage, trachea, things of that nature there. So it's really the carotid triangle that has the bulk of the stuff that we look for. So things like the contents of the carotid sheath, antecervicalis, cervical plexus, some of that sort of stuff. So let's keep going. Know anything on this slide relative to the sternocleidomastoid muscle? And this will be something all semester long. You've got to know this muscle and all about it. So you know that it's got an origin from down on the sternum and the clavicle, inserting onto the mastoid process. It's innervated by a spinal accessory nerve. The other nerve you learned relative, or muscle relative to spinal accessory was trapezius. And know its action, what I've got listed here, unilaterally versus bilaterally. Okay? So there is the sternocleidomastoid. Know everything about it. Okay. So there's some stuff on here that you don't have to know, because I'll be coming back to this slide after a root of the neck. So anterior scalene, to some extent middle scalene. Anterior scalene is a big landmark structure. I'll talk more about it when I talk root of the neck, because you can see a whole bunch of other nerves inside of here. You need to know what you've learned so far: anterior to the anterior scalene, posterior to the anterior scalene. For your purposes, remember, between the two scalenes, and probably on my slides I refer to this as the interscalene triangle. That's where the brachial plexus and the subclavian artery pass between. So posterior to the anterior scalene would be brachial plexus, subclavian artery. Anterior to the anterior scalene is going to be the subclavian vein, suprascapular artery, transverse cervical artery. Yes, some of you might have learned the phrenic nerve is there. That'll be what I come up with later. I don't expect you to know that now. Pardon?
Transverse.
Subclavian,
Anterior to the anterior scalene is subclavian vein, and the two arteries you had to learn. Remember, you had to learn 3 arteries for like in here. Transverse cervical above, suprascapular below, and then subclavian artery. The 2 small ones are anterior to the anterior scalene. The big one is posterior to the anterior scalene. Okay? Yes?
Are you considering that branch off of is that off the brachiocephalic artery, or would that be the subclavian? I'm sorry.
What are you talking about? I'm sorry.
Where the suprascapular and the transverse cervical
This?
branch.
Are you talking about this thing?
Yeah, is that?
Have you even learned about it yet?
No.
Why are you asking me?
Okay, true. Yeah.
Root of the neck, coming up, neck
Okay,
root.
okay.
There's a bunch of stuff in here that you haven't learned about. You haven't learned about vagus, you haven't learned about recurrent laryngeal, you haven't learned about sympathetic trunk. All coming. Yes, sir?
What's the artery coming out of the subclavian behind the anterior scalene?
2 arteries and 1 big one you gotta know. Don't ask me about anybody else. Don't ask me. You don't have to know. Next exam, you're gonna have to know about this little artery and it goes through the brachial plexus. For now, you don't. Don't put stuff in your head you don't have to know.
What about the question on there?
Huh?
Don't have to know. I said nothing about the phrenic nerve. I said, I should have put this slide up there. Sorry. It's a great slide though. I put a lot of effort into this. This will be a key slide next exam. Root of the neck. For now, you gotta know this artery between the anterior middle scalene, these two arteries going across the middle, the anterior scalene. Brachial plexus. That's all you gotta know. You do need to know there's a branch coming off the brachial plexus that would go along and follow this artery, that being the suprascapular nerve, doing that bit. Okay. If I asked you what forms these cervical plexus, you were going to tell me VPR C1 through C4. If I ask you what forms ansa cervicalis, you're going to tell me VPRs C1 to C3. Okay? If I ask you where does the, oh my God, don't even go there. Okay, never mind. Ansa cervicalis C1 to C3, cervical plexus C1 to C4. I am not expecting you to know which individual VPRs form any of those sensory branches. Like you wouldn't have to know that supraclavicular is formed primarily from S3, S4, or C3, C4. Sorry. You don't have to know that. No. Yes, sir. A VPR. A VPR, ventral primary ramus, is, you gotta go back and watch the thing from we did. Spinal cord. Two roots come together, form spinal nerve, splits into VPR, DPR. What I do want you to know, it's a good question, a good prompt, because what I do want you to know is, what type of innervation does a VPR provide?
Sensory and motor.
Both sensory and motor. Okay? That I want you to know. All right? But other than that, not so much. So when you look at this, from the cervical plexus, there are sensory innervation, there's motor innervation. Sensory innervation from the cervical plexus by 4 specifically named nerves you learned about. Okay? So supraclavicular, transverse cervical, greater auricular, lesser occipital. They are sensory only. They do not provide any motor innervation. If you cut one of those, you've lost sensation. I'll go over the area in just a minute where you lose sensation to. Okay? Motor innervation from the cervical plexus is going to be by either ansa cervicalis or C1 nerve only. All right? The cervical plexus provides motor innervation to the infrahyoid muscles. All of the infrahyoid muscles are innervated by ansa cervicalis except one, thyrohyoid, C1 only. Okay? Now, I use it as a good example. If you cut VPR C3, I'm going to tell you right now, I have nothing on the test like this. If you cut C3, understand, you would affect some sensory innervation, you'd affect some motor innervation, you'd affect some things that weren't part of cervical plexus, such that you'd also affect the phrenic nerve, because it's C3, C4, C5. So these VPRs contribute to a lot of different things. We're seeing coming up in the future, we'll do brachial plexus, C5 to T1. Okay, so if you cut C5, you'll affect diaphragm, you'll affect part of the brachial plexus. These VPRs go to a lot of different things. But I want you to know sensory and motor, and what are they sensory to?
Can you say this? Can you say the sensory ones again? The 4 sensory?
The 4 sensory ones are supraclavicular, transverse cervical, greater auricular, lesser occipital. Yes, sir.
Are all plexi formed from ventral primary ramuses?
The question is, are all plexi formed from VPRs? The answer is no, but for the most part, yes, and you don't care. We're probably not gonna talk about sacral plexus, but the reason you could even answer this about no. Think about something like the esophageal plexus, the cardiac plexus. These are plexi that are autonomic plexi. So there's all kinds of different ones. Plexus is a network. We have all kinds of networks in the body. Okay. So there's the 4, and then what you need to know, is where they go to. So make sure you understand, remember, these sensory nerve, if you're sensory, general sensory, you're going to skin. If you're motor, you're going to muscle. So these 4 sensory branches go into skin of the neck. Supraclavicular, all the skin kind of above where the clavicle is. Transverse cervical, going across the neck, right below, and even below the chin, neck, this area. Greater auricular, going up, it's the one we always point out, it's the exception on the face, goes up to the angle of the mandible, so the auricle of the ear, a little bit behind the ear, less occipital, way back on the occipital bone. So have a feel for the distribution of these nerves. Where you would lose sensation to.
I don't know about that, but it hurts more.
Action. So the infrahyoid muscles, they're named below the hyoid bone. So when they contract, remember they shorten. So their primary function is to pull down the hyoid bone or cartilage. As we swallow, that's what's going to happen. Okay? So if you think about it, if I am sternothyroid, okay, I'm not moving the hyoid bone directly because I don't attach to the hyoid bone. I attach to the thyroid cartilage. So that's why I say they move the hyoid or thyroid cartilage, because when they contract, they're going to pull stuff down. Also, they change position. We'll learn later they're going to, at least with sternothyroid especially, it'll be involved with changing position of the larynx so that we can make different types of sounds. Suprahyoid muscles, I think those are some that I gave you, origin, insertion, so make sure you know those. One of the biggest things is knowing the innervation of them. 2 muscles are innervated by cranial nerve 5, B3 particular. 2 are innervated by the facial nerve, cranial nerve 7. All right? So infrahyoids receive innervation from the cervical plexus. These receive innervation from cranial nerves. And these 2 in particular can function in multiple directions, so that if I wanted to open the mouth, in that case I would make this my origin, this my insertion, such that when the anterior belly contracts, and even mylohyoid, it can pull the mandible down. If I want to swallow and then elevate the hyoid bone, this would become origin, this would become insertion, and that's how I pull the hyoid bone up. Those are muscles that can switch kind of origin, insertion. Know your 4 infrahyoids, know your 4 suprahyoids, and their innervation. That should be easy enough. Ansa cervicalis. Make sure, especially lab purposes wise, you're looking for, everybody's looking for the loop. Easy enough. Remember, it has that superior root that has its attachment up here to the hypoglossal nerve. And if you find where that superior root is, come along in the anterior direction, and there you should see the C1 nerve coming off, and it's right over towards thyrohyoid. Remember, these 2, ANSA and C1, are not a part of the hypoglossal nerve. They just hitchhike along with it. They're wrapped up in the same connective tissue. Yes, ma'am?
Does the superior portion be below the C1 area, or?
Would it be posterior to it? The answer is yes. Below it to it, I don't even know what below means.
Inferior?
That's not, would it be inferior to it? Typically not so much. It's based on about the same superior, inferior level. It's more, look, this is always anterior, that's posterior. No?
So I didn't see what
It's
you
on the
meant.
side, so I'm saying, if you think about, this is anterior, that's posterior. They're on about the same plane as far as superior, inferior. It's more, this, you can always see the loop. Follow it back up, and then follow anteriorly, and you should see that little nerve. That's not on every one of the models in there, but that's an easy way to find it. Okay? And then structures in the carotid sheath, that should be easy enough. Everybody should know. Is it my next slide? Coming up. Carotid sheath, lateral is the internal jugular vein, medial is the common carotid artery, posterior is the vagus nerve.
Can you post this?
Pardon?
Can you put this on Canvas?
Everything I'm talking about, you've got except for a couple slides.
Yeah, these slides.
Uh-huh. Yeah. So we'll see. Okay, what two structures pierce the thyrohyoid membrane? Internal laryngeal nerve, superior laryngeal artery. Okay, what is the superior laryngeal artery a branch of? Superior thyroid artery. What's the internal laryngeal nerve a branch of? Superior laryngeal nerve. And what was that a branch of? Vagus. Okay, so here is the thyroid cartilage. Up above here, this membrane would be the thyrohyoid membrane. Here's the superior thyroid artery. There's the superior laryngeal artery, and there's the nerve accompanying it. So that's the internal laryngeal nerve, superior laryngeal artery. Besides which, this is being recorded, so you should have all these slides.
Is it still recording?
Yeah.
Yep.
This bottom part, don't worry about recurrent laryngeal. I said you don't have to know about it for this exam, it'll be next exam. Yeah, that's next exam. Okay, external carotid should know about their 5 cervical branches, so 5 branches in the neck, 5 direct branches. I've emphasized multiple times, these are branches that come directly off of the external carotid, because what's the branch that's not a direct branch that you had to learn? Superior laryngeal. It's a direct branch of superior thyroid. So typically you will see superior thyroid, lingual, facial, occipital, and then I don't expect it to, on Wednesday, but if there was an ascending pharyngeal, it would be coming off at the bifurcation where the two split and then kind of going straight up. Remember the relationship of the occipital artery with the hypoglossal nerve. They kind of wrap around each other. There you go. A lot of reason, some of this other stuff, it's stuff that I didn't even talk or teach about, so it's just going to cause people to ask me questions I don't want to go over because I'm not going to ask you about it. Okay. I've already talked about actions, innervation of these muscles. Make sure you understand that for the infrahyoids, there's 2 muscles that are superficial, omohyoid, sternohyoid. Deep to the sternohyoid would be sternothyroid, thyrohyoid. Make sure in the lab you'd be able to identify particularly those 2, because it's a little bit harder on those models to be able to see them clearly, but make sure deep.
What was the superficial one for that?
Sternohyoid and omohyoid. All those muscles innervated by ANSA except thyrohyoid. Talked about they can have dual actions. So when you look at this slide, here's sternocleidomastoid, and here are structures you can see relative to that muscle, either superficial to it, posterior to it, deep to it, whatever. This point is Erb's point, and this is where the 4, if you will, supraclavicular branches, the 4 sensory branches, the cervical plexus, will exit out. So here are the supraclavicular, transverse cervical, great auricular, lesser occipital. And then in the same area, you can typically see a branch that comes from deep to sternocleidomastoid and then travels and goes deep to trapezius. It's a motor nerve, spinal accessory nerve, cranial nerve 11. That's why you don't see it coming off and going superficial to any of these muscles, because it's not a sensory nerve, it's a motor nerve. That's the spinal accessory nerve. All I want you to know is that the external jugular vein lies superficial to sternocleidomastoid. I don't care what you know about where it drains, because it's a complicated pathway. You can see it gives rise to a lot of different things. And then deep to sternocleidomastoid would be the internal jugular vein. Yes?
If you would pin the supraclavicular nerve, would you pin a branch of it, or would we pin multiple parts?
You're
of
saying
it?
would it be tagged here
Yeah.
versus one of these things or whatever? I think easy enough. I've seen on most of the models, you probably hold up like 3 of the, I don't think we would do just, I don't think it really matters, honestly, the more I think about it. Obviously, you must have some reason why you're thinking it must be, help me out here. What's the concern?
Just like the one that's
for this posterior, I don't want to confuse myself with another nerve that's coming out, like,
I think you would be hoping supraclavicular nerves are tagged on Wednesday. So usually it's easy enough to like hold up some or put it such that you can see it's going down to the clavicle as opposed to deep to trapezius. I don't really think there'll be a confusion on that aspect of it. Okay. Oh, deja vu all over again. Already talked about that. Ah, yeah. Make sure that relative to the common carotid and its branches, you know about the carotid body, the carotid sinus, and all you need to know is the carotid body is a chemoreceptor. It's monitoring basically pH and oxygen levels inside these vessels. The carotid sinus is a swelling that's located in the internal carotid artery. Okay, so just know where those are located, what they do, and you should be good. Yes. The carotid body is like it says on the slide, in the slide in your notes, a chemoreceptor. And the carotid sinus is it's a pressure receptor. It will, as the internal carotid, the stent swells or contracts, it's basically letting you know what blood pressure is. So if you were bleeding out, let's say, and all of a sudden blood pressure went down, it's going to signal the heart to start pumping more and getting more blood out there. Or is it something you're becoming, maybe if you were our little patient Cesar, and you're getting a little hypoxic, maybe your carotid body's going to sense that and make some changes and try and help them out. This is just my reminder. So external jugular superficial to sternocleidomastoid, internal jugular, it's being cut away, it's deep to sternocleidomastoid. I don't think I've got too much more. So this was what I talked about earlier, contents of the carotid sheath, internal jugular vein lateral, common carotid artery medial, vagus nerve posterior. Ah. Awesome. So what's left? Skull. Okay, so as I mentioned for skull, I didn't mention anything for skull basically. Okay, my suggestion is go to his PowerPoint, and I think the bigger things to look at are, in his slides, it'll show like a particular bone. So maybe it's temporal bone. And he lists different structures, whatever. So you'll be seeing more, I think, which of these structures is or isn't part of this bone. So know which things you can find on the different bones of the skull. All of the following will be located on the temporal bone, except for one, which is the exception. Or which of these will be located on sphenoid or something else. I think if you know most of the skull stuff from that standpoint, you know what you need to know. In the lab, tag will be most of the stuff that he has emphasized and made a big point about. And he's very fair about tagging the things that he's emphasized, that he's told you were important, that he wants you to know. On this one, it should be pretty general structures versus the big full skull exam you got coming up. That'll be more detail and will be more things to know, if you will. But that's my best suggestion for what's on skull. Okay? Yes, ma'am.
There's a section on the checklist for the skull, and it says sutures and landmarks, but we didn't go over that. Should we still know it?
This question, if you didn't hear it, was about sutures and landmarks. Yeah, I know exactly what's on there. Those are important. For this exam, no. I don't think it's something that will be on the, we'll get to it later. When you start doing, they're used primarily for orthodontic purposes, like, for doing x-rays and things. They're valuable. I mean, you need to know them for sure. I just don't think they'll be tested on this test. He didn't talk about it, he didn't make a big point about it, and he pretty much always talks about what he thinks is important. But they are valuable resources to you. When you start doing lateral cephalograms and you want to talk about how much have you moved the mandible or mid-face or something, you have to have reference points where you can make measurements to know how far have you advanced, say the mandible or maxilla or whatever, and that's how you do it. So we'll talk more about them, especially in radiology, orthodontics, we'll get more about it as well. What else? What other questions does someone have? Jared, you're an awesome dad, that's all I
Kind
gotta
of
say.
impressed with my storage.
Yes, sir.
Oh, I was gonna ask about human bio.
About human bio. Wait, one minute.
Exploding.
Is that- Yes, human bio will be what causes everybody the most grief this semester. It's only one course, that should be, I mean, I don't think there's, last semester was probably at least two. This semester, I think head and neck, operative will challenge you, but they're manageable. Human bio, what you saw last semester is what you're gonna see this semester. Very much so. Okay, everybody.